Hi guys, welcome to this free anaesthetic tutorial on local anaesthetics for the primary Frca. And my name's Dan. I'm an anaesthetic ST3 in Mersey. I'm currently doing some revision for the final, so one way that I feel I maximise my revision is by trying to make some videos and some audio tutorials. So I thought I'd share this one that I made the other day. Do let me know if you get any benefit from it. Let me know if there's anything that you think needs to be added or taken away or is completely wrong, because I might get asked about it in my exam and I don't want to look silly. One other thing to flag up to you is that we're organising the Mersey Video Viva Club for the November primary SOE. I'll leave some details in the show notes. So if you're looking for structured, convenient, zero cost, peer-to-peer Viva sessions where you're just looking for a bit more practice, then maybe have a little look at the programme. And we've already had 90 people sign up, so hopefully you'll be in good company. Without further ado, let's get on with this. So a couple of learning objectives. So first of all, we're going to understand the basic structure of local anaesthetics. We're going to relate that to the function and potential adverse effects of local anaesthetics. Describe the pharmacodynamics, the pharmacokinetics. We'll talk about some common local anaesthetic agents that we use in practice. Okay, so local anaesthetics generally suppress action potentials in excitable tissues, and they do this by binding to the voltage-gated sodium channels. They inhibit action potentials. They do inhibit pain fibres, but they also inhibit other fibres as well. By inhibiting the action potential, they block transmission of pain. So in terms of the anatomy and physiology of the nerve, first of all, so the nerve's function is to transmit electrical activity to and from the central nervous system. We've generally got a number of different classifications of fibres, but it's the A fibres that transmit the action potentials fastest. And they do this due to myelination and having a larger diameter. There are 4 different A level fibres. The A alpha fibres supply muscle, the A beta fibres, they transmit tactile sensation, the A gamma fibres innervate muscle spindles, and the A delta fibres transmit cold and pain sensation. Generally, the A alpha fibres have the largest diameter and therefore the fastest conduction velocity. The A delta has the lowest conduction velocity of the A level fibres. There are also myelinated B fibres, and they're autonomic preganglionic fibres. They've got a slightly lower diameter than the A fibres and so have a slightly slower conduction velocity. And finally, we've got unmyelinated C fibres, and these transmit dull pain from skin and viscera, and they, as you might imagine, demonstrate the slowest conduction velocity. If we're doing surgery, if the patient suffered some trauma, generally there's local inflammation which activates pain receptors, and these are located in the free nerve endings of the A delta fibres, and they can be found in a number of places such as skin, muscle, joints, bones, and even organs. And this results in the activation of a voltage-gated sodium channel which sits on the inside of the membrane of the nerve. They're also present in the myocardium as well, which is important. The channel is one of 3 states. It's either resting, it's open, or it's inactivated. And so let's talk about the resting membrane potential and how that's formed. So in the resting state, the neuronal membrane potential is around 70 millivolts, and this is kept in check by the sodium-potassium ATPase which sits in the membrane, and it causes a greater concentration of potassium inside the cell, pumps out sodium to the outside of the cell. It is possible for the potassium ions to move down their concentration gradient passively, so they will leave the cell passively. However, the negatively charged anions, the most common is the plasma protein, that remains within the cell, and that's what generates the negative resting membrane potential. How is the action potential formed then? So we have nociceptor activation. This causes opening of the voltage-gated sodium channel. And once the threshold potential, which is around minus 50 millivolts, is reached, this causes coordinated sodium channel opening. And that will cause a flux of sodium into the cell. This flux of sodium into the cell causes an action potential to be produced, and this has a peak potential of about plus 40 millivolts. The sodium channel will then become inactivated. There'll be an efflux of potassium ions, and that is what causes repolarization of the nerve back into its resting state. And then the sodium-potassium pump will restore order, and the resting membrane potential will be restored. So then how do local anaesthetics work First thing to say is that the lipophilic, the unionized local anesthetic molecule, is able to cross the lipid bilayer of the membrane of the nerve. When it gets into the nerve, the molecule will then dissociate and it will reach a new equilibrium. And this is dependent on a couple of factors. So one is the intracellular pH, but the other thing is the pKa of the local anesthetic agent. And we'll talk a bit more about pKa in a moment. It's the ionized form of the local anesthetic agent that binds to the sodium channel. And this is reversible and in a concentration dependent manner. And given this, the local anesthetic nerve blockade will also be concentration dependent. So we know that local anesthetics can't discriminate between the different types of fibre, but what they do is provide variable blockade to each different type of fibre. And during epidural anaesthesia, sympathetic blockade requires lower doses of local anaesthetic compared to other types of fibre. And this can be demonstrated because sympathetic blockade reaches a higher dermatome compared to other types of fibre for a given dose of local anaesthetic. The next most susceptible type of fibre are those that carry temperature and pain. The next is followed by proprioception, and finally their largest diameter motor fibres are then most resistant to the local anaesthetic action. But during an epidural, or for a spinal for that matter, it is important that the anaesthetist explains to the patient that whilst they shouldn't be able to feel sharp pain because it should be blocked, they may still be able to feel pressure because of this differential blockade to the different types of fibre. So there are some potential adverse effects of local anaesthetics. Lidocaine and Bupivacaine are probably the most common type of local anaesthetic that we use. And because myocardial cells also have sodium channels, it is possible for local anaesthetics to bind to those sodium channels. Bupivacaine is felt to be more risky because it has a higher affinity for the myocardial sodium channels and dissociates more slowly, and therefore it could accumulate in those tissues. And that's why there is a higher risk of re-entry induced arrhythmias with Bupivacaine. That's essentially the reason why we tend to use levobupivacaine, and I'll talk a bit more about levobupivacaine in a moment. So there are a number of factors about the preparation of the local anaesthetic agent, and they generally are formulated as a hydrochloride salt, and that makes them water soluble. They contain preservatives, they can contain fungicides, and generally only the preparations without any additives are suitable for neuraxial administration. However, we know that something like heavy marcaine, or for example, contains glucose, and that is safe. Adrenaline or felipressin can be added to solutions, and this slows down absorption from the site of injection, and this essentially is to increase the duration of blockade. We want to avoid adrenaline containing preparations in areas such as, for example, the penile block, where there is end vascular structures where that could accumulate and cause tissue necrosis. So a bit about the pharmacological structure of the local anaesthetic molecule. So it contains three principal parts that we need to know about. The first part is the aromatic group, the second part is the intermediate link, and the third part is the tertiary amine. And it's the intermediate link which is really important for categorizing the local anesthetic agent. And local anesthetic agents can be either esters or amides. So taking the esters first, examples are cocaine and Amethicane. The esters are generally metabolized by serum esterases. However, cocaine is a little bit different, and that's hepatically metabolized, and I'll talk a bit more about that in a second. The other thing to say about the esters is that there is an increased risk of allergic reactions, and this is because of this molecule called PABA, which is para-aminobenzoate. It's a metabolic intermediate, and so that can lead to allergic reactions. And then the amides, so there are a number of amides. We've talked about lidocaine and bupivacaine being the most common. Generally they're metabolized by the liver, and generally they're renally excreted as well. So now there's some key pharmacology that we need to know about, and there are three things that we should talk about. So one is speed of onset, one is potency, and one is duration of action. So the speed of onset first, and that's dictated by the pKa and also the molecular mass of the local anesthetic agent. Potency is dictated by lipid solubility, and duration of action is dependent on protein binding. So what is pKa? Well, the dissociation of the local anaesthetic molecule is dependent on its pKa and also on the pH of the environment into which it is injected. And the pKa is the pH at which the unionized and the ionized components of the local anaesthetic molecule exist in equal amounts. Given that local anaesthetics are alkaline, they're bases, the higher the pKa, the greater the ionized fraction, and the ratio of the unionized to the ionized fraction can be described or worked out by the Henderson-Hasselbalch equation. So the Premier League restarted this weekend, and the way I remember that equation is think about Jordan Henderson and Jimmy Floyd Hasselbalch having a right old scrap. And as you can see here, it's that's essentially how you work it out, with the A- in brackets being the ionized form and the AH in brackets being the unionized form. So how can we apply this principle of pKa to agents that we're familiar with? Well, the first thing to say is that we know that the rate of diffusion across the membrane is directly related to the proportion of non or unionized drug. In order for the drug to get through the lipid bilayer, it needs to be unionized. Local anesthetics, therefore, with a lower pKa have a faster onset of action. Lidocaine has a pKa of 7.8, whereas Bupivacaine has a pKa of 8.1. And because at body pH, Lidocaine's pKa is closer to the pH of 7.4, Lidocaine has a faster onset of action. Things to be aware of though: in infected tissue, the environment is then more acidemic, the pH is lower, and that increases the proportion of drug that is to be found in the ionized form. That reduces the amount of drug that can cross the membrane, and therefore it will reduce the action of the local anesthetic agent. And that's why sometimes local anesthetic infiltration doesn't tend to be particularly affected around areas of abscess formation. So coming to lipid solubility next. What we know is that if the drug is more lipid soluble, it will enable more rapid diffusion through the lipid membrane, so the lipid bilayer, and so it will reach the site of action quicker. The greater the lipid solubility of the agent, the greater the potency of the agent. So this means for a given effect, the amount of the agent delivered, or the concentration of the agent delivered, will be lower. We're then going to talk about protein binding. So local anesthetics that have a higher protein binding tend to have a longer duration of action. There are a number of factors which reduce protein binding. So things like low oxygen environments, high carbon dioxide environments, low pH environments. And because of that, because of the reduced protein binding, there is a risk that systemic toxicity can occur because the local anesthetic agent is no longer bound to plasma proteins. It can then be absorbed into the systemic circulation. So we need to be aware of that when we're dealing with more unwell patients. Another concept to think about is vasoactivity. And earlier on, I mentioned about the differences between Lidocaine and Bupivacaine. Another thing to be aware of is that Lidocaine is more rapidly absorbed by the systemic circulation, and because of this, it has a lower duration of action compared to Bupivacaine. Now, one thing that we can do to Lidocaine is to add some adrenaline, and by adding adrenaline, this causes vasoconstriction, and this reduces the absorption of the Lidocaine into the systemic circulation and will increase its duration of action. So we're going to talk a little bit about some pharmacokinetics now, and the first thing is absorption. So the site of administration can affect the systemic absorption of a local anesthetic agent, and therefore it can affect the duration of action of the agent. Generally, if I'm injecting a local anesthetic agent subcutaneously, this has the lowest rate of absorption. However, if I were to inject it intercostally, this has the highest rate of systemic absorption, and therefore we need to be aware of, number one, the duration of action is going to be lower if we inject it intercostally, and number two, we need to think about the risk of toxicity because higher concentrations are going to get into the systemic circulation and go to places like the brain and the heart where we perhaps don't want them to function. The next thing to say is distribution. Generally, ester local anesthetics are less protein bound compared to amides, and when protein binding is increased, that means that there's a lower free fraction of the drug available. With regards to metabolism and clearance, we've talked a little bit about this already, but esters are hydrolyzed rapidly in plasma, and that's by pseudocholinesterases. We've talked about para-aminobenzoic acid, and that could cause allergic reaction. There is obviously a difference in half-life between different agents. Tetracaine has the longest half-life of the ester local anaesthetics. The other thing to be aware of is that cocaine, unlike other ester local anaesthetics, undergoes hepatic metabolism before being renally excreted. With regards to amides then, they undergo hepatic metabolism. And so we have to be aware that in hepatic dysfunction, amide local anaesthetics may accumulate. The other thing is that they avoid the para-aminobenzoic acid, and so the rate of allergic reactions is much lower with the amides. So the next thing to talk about is some common preparations, because in the exam we're often asked to compare two different preparations with regard to their pharmacology and pharmacodynamics and pharmacokinetic. So I'll just talk you through a couple of the common agents. So the first one is Lidocaine. It's an amide local anaesthetic. It has class 1B antiarrhythmic action, can be used to control ventricular tachycardia. It's presented as a colourless solution. It has variable concentrations. It can be given with or without adrenaline, and is also available in different preparations. So for example, as a gel, as an ointment, can be used as a topical spray as well. Salidacane is 70% protein bound. It undergoes extensive hepatic metabolism. It's excreted in the urine, and the one thing to be aware of, its clearance is reduced in the presence of either hepatic or cardiac failure. Bupivacaine is prepared as a 0.25 or a 0.5% solution. Glucose can be added to prepare it for spinal anaesthesia, but due to concerns around cardiac toxicity, its use has more or less been superseded by levobupivacaine. So talking about levobupivacaine, it's an S enantiomer of bupivacaine, whereas bupivacaine has a racemic mixture, so it has the R enantiomer as well. Let me know if you want a tutorial on isomerism. That will be a good thing to learn for me as well. It's prepared as a 0.25, a 0.5 or a 0.75% solution, and the other important thing about levobupivacaine compared to bupivacaine is the dose required to produce myocardial depression or convulsions is higher than bupivacaine, and therefore it's felt to be safer, and therefore that's why we tend to use levobupivacaine more commonly now. Pralikane is another amide anaesthetic agent that you might see. It's less commonly used, to be honest, but it can be used for regional anaesthesia. It's the most widely or the most rapidly metabolized amide local anaesthetic, and it does have a metabolite that we need to be aware of, this O-tolidine, and that can precipitate methylglobinemia, especially if Pralikane is used in higher doses. This is important because Pralikane is used in EMLA, and I'll talk about that in a minute, and that's generally used in pediatric practice. Well, neonates are at the highest risk because they lack an enzyme, this methemoglobin reductase, and so they will be at significant risk of methylglobinemia. Coming to Repivocate next, it appears to be used quite infrequently. I don't think I've ever seen it used. However, apparently it does have some benefits compared to bupivacaine. It's got lower lipid solubility, and this causes a reduction in penetration to the larger myelinative fibre. So essentially it is less likely to cause motor block, it's less dense, and it is of a shorter duration compared to bupivacaine, and so it could be used for epidural anaesthesia, I guess, and there might be some benefits to that. That doesn't appear to be quite widely used. The other thing to say is that, like the other amides, it's hepatically metabolized. Coming to some esters next. So cocaine is probably the one you're most familiar with. It's an ester, as we've said. It's contained in Moffitt solution, so this is generally used quite a bit in nasal cavity surgery. Contains cocaine, sodium bicarbonate, and adrenaline. Cocaine works by blocking uptake of monoamine oxidase. It stimulates the central nervous system. It can precipitate hypertension. It can cause arrhythmia. It can cause high temperatures, and in higher doses, it can cause a number of adverse effects. The cardiac rupture, in particular, seems to be quite worrying. It's highly protein bound, and as I've already said, it undergoes hepatic hydrolysis. Coming back to eutectic mixture of local anaesthetic, this EMLA. When two compounds are mixed to produce a substance, that substance behaves with a single set of characteristics, and that is what the definition of eutectic is. So EMLA contains 2.5% lidocaine and also 2.5% pralikane in an oil to water emulsion. It's got a lower melting point if the substances were found individually, and so it's an oil at room temperature rather than a crystalline solid. It can be used to anaesthetize the skin before cannulation, tends to be used in pediatrics, but it needs to be applied to intact skin. It needs to be under an occlusive dressing, and it needs to be given at least 60 minutes before you're planning on cannulation for it to have an effect. Bupivacaine, another ester, is useful for topical anaesthesia as well. It's got a faster onset of action to EMLA, about 30 minutes or so, and its effects last for 4 to 6 hours. If, like me, you've forgotten in the past to give EMLA to a child on the emergency list, if you think on before 30 minutes before you're planning on putting a cannula in, you can think about giving some Bupivacaine as well, and that would be topical. So we've covered a couple of the individual local anaesthetics, and so I'll leave you with some conclusions then. The first thing is that local anaesthetics work by voltage-gated sodium channel blockade. There are two principal types, the esters or the amides. There are a number of key pharmacodynamic principles that you'll need to know for the Frca exam. That's pKa, molecular weight, lipid solubility, and protein binding, and how those factors affect the action of different anaesthetic agents. You need to know the differing kinetics between the amides and the esters, and because local anaesthetic agents are so commonly used in our practice as anaesthetists, it's a really common question in the Frca, and so I would say it's an absolute key topic to get your head around before doing any of your exams. Okay, thanks so much for listening to that. I hope this format was useful. If you found it useful, do let me know. If you didn't, if you'd have any suggestions or any clarifications or any way that you think we could make these tutorials better, or even if you want to get involved in making some tutorials, do let me know. Get me through YouTube, or got a Gmail account which is freeanaesthetictutorials@gmail.com. Okay, thanks very much. See you now.